From trauma to emergency care. This is Verb Trauma Talk with your host, Dr. Amar Pyari Makhanlal Chauhan.
Hello and welcome to Verb Trauma Talk. I am Dr. Amar Pyari Makhalan Chauhan, and this is season 1, episode number 8. So, topic for today's podcast is very important, and this is very much required in Indian setting, and that is how to develop an emergency mindset. Okay, and let's see what are the various attributes one should possess before he or she should start working in emergency department. So the first and foremost thing is a good training base, a solid training base with varied experience. As they say, the only way to learn swimming is to get into the water. So one must have a good training base. And the second attribute is situational awareness. What's happening with the patient, what's going on in your environment. And it should not be static. It has to be dynamic. With changing, patient condition, your situational awareness should change. So it has to be dynamic. So this is very important. Situational awareness is a very important attribute of those people who are working under stress or during high stake procedure. Okay. So once you have developed that situational awareness, then you must rapidly accept the reality. It should not happen that the patient should deteriorate so that you become acceptable to the reality. That patient becoming sick to sicker. So as early as possible, you should accept the reality that patient is very sick and you need to activate all your resources to save that patient. Okay. And before you start treating the patient, I would recommend for everybody whosoever working in emergency department should have a breathing exercise so that it calm down your sympathetic system, and that breathing can be a very helpful tool. It could be a box or a triangular breathing. So calm yourself while after taking 3 or 4 breaths. And you must have a flexible thinking. You must not be rigid. You must not have a tunnel vision or a rigid lens, because algorithm, yes, they are good, protocols, they are good, but sometimes you will encounter a patient who will not fit into your algorithm. Then you will have to fall back on your creative thinking. And sometimes around that creative thinking, algorithm can be developed. Now, just to illustrate my point, I will cite an example of APGAR scoring. So Miss Abgar was an obstetrician anesthetist, and she was rather, as Atul Gawande described, she was on a sort of punishment posting. And one day her student asked her, like, how can they monitor newborn? Like, who is going to do good and who is going to deteriorate? Then Miss Abgar, jotted down certain parameters and become the basis of APGAR scoring. So this is how the creative thinking can become algorithm. And in our Indian setting, I would cite example of Dr. Himmat Rao Bavaskar. I hope you have heard his name. He is a doctor who, while working in a primary health center in Maharashtra, created, rather through its ingenious thinking, creating an algorithm for treating scorpion bite. And the mortality in that Konkan area fell down from almost 90% to 10% today. So this is how Dr. Bavaskar used his creative thinking to understand the pathophysiology of scorpion bite, and then came out with the algorithm of scorpion bite. Okay, so once that is done, and now it depends on your training, that the patient who has come to you, how do you treat that patient, that sick patient? When I refer patient, that means I'm referring to sick patient. So whether you take that patient as a threat or a challenge. Now there are a million things which can go wrong in trauma with life-threatening conditions. So for that, when you treat patient as threat, then you become resentful, you become annoyed, angry. So these are the signs that you are taking that patient as a threat. That we should not do. We should never do. We must take every patient as a challenge. And how can we do that? We can do that by having our own SOPs, like standard operating protocol or procedure, a checklist, and a good trained team. And among team member a shared mental model so that everybody is on the same page, and you treat that patient as a challenge because everybody is aware of the emerging situation. And you must not have any self talk about yourself. You must indulge in self positive talk that you have been trained for treating sick patient, and you will treat this patient according to your training. Okay. And one more important point, like how can you develop that kind of thinking? You can develop by iteration, by sim session, and through sim session you can have some kind of stress inoculation. So when a very sick patient comes, you don't feel stressed up, and you take that patient as a challenge. And then you must have a plan B. So if your plan is not working, like suppose a plan is not working, then you move on to plan B. And let me remind you that moving to plan B is not a sign of your failure. You must not develop negative emotion about using plan B. Rather, you treat it as a part of your extended treatment plan. And here, when the doctor fails to use plan B, then patient can lose life. And here I would illustrate the example of Miss Bromley. I think her full name is Elenine Bromley, and her husband is Martin Bromley, who is a pilot and nowadays involved in creating awareness about airway, or rather high stake procedure. So what happened that Mrs. Bromley has gone for a routine surgery, throat surgery, and then after paralyzing, the doctors were not able to intubate her, and then they called senior persons, senior doctors, everybody came in, and nobody could intubate her. But they did not move on to plan B of doing a surgical cry, and in that process, the patient lost her life. So it is very important that we must have a plan B, and we must not feel guilty or develop negative emotions about using plan B. And one another important step in developing emergency mindset is you must mentally walk through algorithm several times before the patient comes, or when you are about to do a procedure, because this is a very important tool. And if you do that, it is unlikely that you will fail. Okay. Now moving forward, whenever you are involved in a high stake procedure or resuscitation, or you are resuscitating a very sick patient, then you must harness wisdom of the room. Although that's a difficult scenario in Indian setting, but we must promote everybody else view when we are acting as a team. Is there anything else we are missing, or anything else which can be done? So this is how, like, people before the science became rampant used to solve their problem. And there's a book, Wisdom of the Crowd, by James Surowiecki, and it tells about the wisdom of the crowd, and that translates into wisdom of the room. That room means emergency department. So you must harness the wisdom of the room. Okay. So the third attribute is you must avoid cognitive biases. Now, biases are our thought process to simplify complex thing at subconscious level. Oh, it may not be logical, but we sometimes are biased. And here I will just talk about two biases. Of course there are many kind of biases, but I will just stick to two, just to explain what are biases. So one is anchoring bias. For example, we try to anchor our treatment when we get the first information report, or when the patient or tries, or somebody has written a diagnosis. So in my experience, in my personal experience, I have seen that everybody tend to follow that diagnosis. So this is becomes our anchoring bias. So we must get rid of this anchoring bias, and must have a fresh look whenever a patient comes. Okay, the second bias I would like to talk is the confirmatory bias. That something we are comfortable with explaining, rather than going by the evidence or going by the logic. So, for example, in India, if a patient of mm, chest with infiltrate, and we have a chest problem, and we get his chest x-ray and they're infiltrated, then we tend to think that this is straightforward pulmonary tuberculosis, and that shows our confirmatory bias. And this is not how AIDS or the pneumocystic canine pneumonia was discovered, because when Michael Gottlieb, he he was getting a number of patients of pneumonia and they were not fitting in algorithm, and he was basically became out of this conventional bias, and then he started looking for a different pattern, and then he discovered pneumocystic carine pneumonia, and then AIDS was discovered. Okay. And the third thing I would like to talk about is the avoid opportunity for unnecessary failure. What do I mean by that? I mean to say that please don't ignore small error when you are dealing with sick patients. Now, just to give an example, if there's a patient who is ventilated and he developed or she developed leg swelling, then we must not ignore, because we don't want that patient that we find crashing because of the pulmonary embolism. We must think in terms of DVT, and then and there only we must do a Doppler to rule out that. Because if you heard about aviation crisis, and most importantly like the KLM flight crash in 1977, then they are basically because of ignorance of the small clues which were ignored, and that lead to disaster. And we can eliminate disaster by having a closed loop communication. Although everybody is talking about closed loop communication, but I don't see much this communication in practice. So please try to have closed loop communication with your staff or your team member, and make sure that other person has understood your point of view, because sometimes we assume, and that leads to sometimes error converting into disaster. Okay. And next step, next attribute, or the next dimension is to have a pre-mortem exercise. Now, pre-mortem is a new concept. It says that something you plan, or some patient you are treating has died. Just to give an example, like a patient of chest pain comes or is coming, but you imagine that the patient has died. So, what are the possible reasons that had could cause his death? So this is known as pre-mortem. So these causes of the chest pain, patient dying, it could be MI, or arrhythmia, or cardiogenic shock, or pulmonary embolism, or tension pneumothorax, or dissection, or maybe esophageal rupture, or maybe some mediastinum problem. So now we are doing pre-mortem. Patient has not come. So this is the way we can now pay attention to all those causes which can, cause death of such patient with chest pain. So this is how, like, you think that you plan, your treatment plan has failed, and what are the possible reasons before the patient arrives. So you dissect those reasons. So this is a very important strategy when you are dealing in emergency department. Okay. The next is dealing with uncertainty. This is a difficult aspect, and this is a gray zone when you are not sure about your treatment plan. Okay. But here, I would recommend that you must start building from your core values. Core values are like a basic principle, like primum non nocere, like don't do further harm if you are uncertain about treatment plan, or you can symbolize only ABC rather than going for a definite treatment plan. So when you are in uncertain circumstances, do at least, and avoid changing things which are not under your control. So very sick patient not able to resuscitate, don't collect or pent up your negative emotions, and never, never, ever waste suffering over a patient. So when you're dealing with uncertainty and outcome is not good, then you must think next time what are you going to do differently, or you talk to your colleagues or your senior, how would they have treated that patient, so that you get a different perspective. Now, the lastly, one has to be insightful, ingenious, or intuitive. Look for curiosities or contradictions. So, just to give an example, curiosities. When Alexander Fleming found that his petri dishes where he was growing Staphylococcus aureus, and one of the petri dishes which were came in contact with the mold, then were not growing these bacteria colony, and then this is how the penicillin was discovered. Similarly, if you find contraindication in your treatment plan, look for those things. And this is how Dr. John Snow discovered cholera, because everybody during those time was thinking about miasma theory. That is the bad air which is causing the cholera, and it is not a one-borne disease. So he looked at the contradiction. So when are you in the emergency department dealing with sick patient, must look continuously and consistently about curiosity or contradiction in your treatment plan. And the next step is that must have a skill which is metacognitive thinking. That means thinking about your own thinking. That is very important for future learning. And most importantly, last but not the least, is learn outside medicine. That is very helpful. That's helpful for me, and bring something new to the table. And if you learn from different field apart from medicine, then your thought process is enlightened, and you become more competent to make decision. And with that, adios, hasta pronto. See you in next episode.